question. Thank you.
Okay, well, thank you, everyone, and good evening to you. So I'm going to talk about an important topic, which I think is more relevant to those who see children, but it's also important for adults as well. And it's important to recognize it's a very many times confusing issue, and that's the issue of food allergies. So what I'm going to review with you is, what are well, first of all, some definitions of what is a food allergy. We'll talk about some basic mechanisms, and then we'll really focus on the clinical aspects and the practical aspects. And I would encourage all of you to keep your cameras on, and if you have any questions, please chime in. So, when we say food allergy, it's a very nebulous term, and it's often confusing. So food allergy is any adverse health effect, okay? And this arises from a specific immune response. So you need to have an immune response for it to be categorized as food allergy, and it has to be reproducible, okay? That is the key thing. You don't develop food allergy one time and food allergy and not having food allergy the other time. It has to be reproducible with the same food. Now, the reaction itself, the immunological response, could be Ig mediated, okay, so mast cell mediated, or it could be non-mast cell mediated, non-Ig mediated, or it could be a mixture of both. Okay, and we'll talk about that. And the key here is you need to have both exposure and you need to have, to the food in question, you need to have clinical symptoms. So that's the key. When we're doing skin testing or when we're doing in vitro blood testing, that will only show you if you have Ig-mediated sensitization. If you have IgE-mediated antibodies against the food, it is not the same as having an allergy. Okay, a little bit like in rheumatology, a positive ANA by itself doesn't mean anything. It's meaningless. So you have to have symptoms. Or even if you have, positive, let's say, double-stranded DNA, that doesn't necessarily mean that you have the person has lupus. So you have to have symptoms in addition to sensitization. This is very important, especially in India. So in India, if you look at the data, a quarter of adults in India are sensitized to foods, but only 1.2% are actually allergic. So having antibodies is very common. It doesn't mean anything. And so it's important to recognize that. Okay, so here's a table. Again, you're talking about adverse food reactions. So you have immune mediated, and this is what we call by, quote unquote food allergies. And then you have non-immune mediated. So non-immune mediated is where you don't have, the immune system is not involved. Example, lactose intolerance, that has nothing to do with immune system. So that's a food intolerance. So it could be metabolic, like lactose intolerance, fructose intolerance. It could be the effect of the food itself, like pharmacological effect, like caffeine. Okay, a lot of people, they get jittery, can get diarrhea with too much caffeine. That has nothing to do with that's not a food allergy. It could be like food poisoning, like scrumgoid. If you eat raw, uncooked fish, you can get poisoning. So that's not a food allergy. And other things like sulfites. Some people, MSG sulfites, they just don't, their body doesn't tolerate them. And so those are defined as others. So anything where the immune system is not involved is non-immune mediated. Now on the immune side, when the immune system is involved, so you can have Ig mediated. These are immediate reactions. This involves mast cell degranulation. This will cause hives. This will cause urticaria. It will cause urticaria. It can cause oral allergy syndrome. It can cause anaphylaxis. You have things that don't involve IgE. An example is food protein-induced enteropathy. Okay, so that's your cow milk intolerance. It's actually, it's a T cell mediated. It has nothing to do with IgE. Celiac disease is another immune mediated, but it has to do with antibodies of gliadin. It has nothing to do with IgE. And then you have certain entities, eosinophilic esophagitis, atopic dermatitis, where it's both. It's what we call mixed. Okay, so here's an example here. Ig mediated, these are classic is anaphylaxis, where you eat the food within 30 minutes to 2 hours, you get a reaction, you have activation mast cells. It could be a systemic reaction or it could be localized reaction. Here, there is a role for allergy testing. There's a role for in vitro blood tests to IgE. On the opposite extreme, you have non-IgE mediated diseases where IgE has no role. So there's no role for skin testing. There's no role for IgE testing. And then in this category here, EOE, atopic dermatitis, it's kind of mixed. Mainly, you could have IgE antibodies, but there's really no role for skin testing or specific IgE antibody testing either. Okay, the only time you would where skin tests play a role is in the classic IgE reactions, so anaphylaxis or allergy syndrome. Okay, so how do you distinguish? So what is a classic IgE food reaction? Again, it has to occur immediately. Okay, so immediately, it assumes that you have preformed IgE antibodies in your system. Those IgE antibodies are sitting on mast cells. So upon re-exposure, within minutes to 2 hours, you get mast cell degranulation. And by the way, the hallmark of mast cell degranulation is you release histamine. That's what causes itching. Now, the severity could be, it can vary. So you have anaphylaxis, which is where you have multi-system involvement, or it could just be localized. Localized would be just itching in the mouth, the tongue, the throat. And just to remind you how this occurs, so you have a period of sensitization. And in the case of food allergies, most food allergies are actually occur in children who have a history of eczema, atopic dermatitis. So what happens in atopic dermatitis is you have a break in the skin barrier. And because, food antigens are prevalent, the child will touch the food, the food, and the antigen will enter through the skin. It will go through the skin barrier where it'll get picked up by antigenic presenting cells. These are called Langerhans cells. And by the way, food allergens are all proteins. So the dendritic cell will pick up the protein. It will divide up the protein into peptides and present it on this molecule. It's a glycoprotein called MHC class 2, where, in the right milieu, by the way, this dendritic cell will then migrate into the regional lymph node where it gets picked up by Th2 cell, and the Th2 cell will then produce IgE antibodies against this particular food epitope. So epitope is a very, tiny portion of this peptide. And in the presence of interleukin 5, interleukin 4, interleukin 13, it will cause a B cell to produce IgE. So the B cell is now producing IgE against this particular peptide. The IgE will then get bound to mast cells, which are predominantly in the tissue, where it will reside there on the mast cell, and it will lay dormant. And this, half-life is extremely long, about 70 days. And then upon re-exposure of the same food, and this would be by oral ingestion. So here it's, the sensitization occurs primarily through the skin. The re-exposure occurs predominantly orally. You then have mast cell degranulation. If you have binding of the food antigen to the IgE specific antibody, you get cross-linking, mast cell degranulation, and that's what causes symptoms. And if you recall, with anaphylaxis, you have early symptoms where you have preformed mediators that are being released. So histamine is one of them. There's also tryptase, which is released, which is what we actually measure in the case of anaphylaxis in the blood. That's released, within 4 hours. It's released immediately, but it stays in the system elevated for 4 hours. So that's one of the measures of anaphylaxis is serum tryptase. And then later, Mediators would be your cytokines, IL-4, IL-5, IL-13, which in turn will recruit inflammatory cells such as monocytes, eosinophils, and these cells will then will be then trafficked to the areas and cause sustained inflammation. So when you have mast cell accumulation, you have early phase, and then you have a late phase. All right, so we talked about this general mechanism, which applies to all Ig-mediated reactions. Now, specifically about foods, there are two categories of antigens. You have class 1 antigens, and by the way, what are the common food allergens? So you have milk, egg, peanut, tree nut, soy, wheat, and sesame. Those account for most allergic reactions in children. In adults, fish and shellfish are also included in the list. And keep in mind that this data here is, for Western countries. In India, there may be slight differences, but in general, these are the common food antigens, where 90% of all reactions occur amongst these food antigens. And what is unique about these antigens is that they're water soluble, they're acid stable. Okay, so that's why when you ingest the food, the stomach acids don't break down the protein. They're resistant proteolytic enzymes, and they're abundant. So within the food source, these are very common antigens. Okay, so these are what we call class 1 antigens. These are mostly responsible for anaphylaxis. And then you have more minor antigens. These are called class 2 antigens. These are mostly present in foods of plant origin and generally won't cause anaphylaxis, but will cause localized itching and swelling, what we call pollen food allergy syndrome. On the food itself, you have the peptide resembles very closely with pollen. A good example is birch pollen, which is a tree pollen. So many of the pitted fruits like apple, peach, plum will contain a protein that resembles birch pollen. So if the patient is sensitized to birch pollen, if you eat these foods fresh and raw, it will cause localized itching of the mouth, the throat, the tongue. These class 2 antigens are sensitive to heat. So when you cook them, okay, so if you heat up the food, if you cook them, if you bake them, generally these foods are tolerated because it breaks down the protein. They no longer cause problems. So again, class 1 are the major antigens, class 2 are the minor antigens. Here you've had severe reactions, and here generally only itching of the mouth, the tongue, the throat. And we call these class 2 antigens, we call it oral allergy syndrome, also known as pollen food allergy syndrome. Again, it's a reaction due to cross-reactivity of the fruit or vegetable or seed, or nut sometimes, like in the case of peanut, for example. Peanut also cross-reacts with birch pollen as well as certain grasses. Hazelnut also cross-reacts with birch pollen. So the reaction is generally mild, generally limited to the oropharynx. And most of the time you can tolerate the food if they're cooked. Okay, so this is a pollen food allergy syndrome, and the common cross reactants are with birch and with grass pollen, with ragweed. And here are some examples here. Now, is food allergies a problem? And it is increasing. So the prevalence of food allergies appears to be increasing worldwide. We see that in the last 20, 30 years. This, patients with food allergies generally may have asthma, they may have allergic rhinitis, they may have atopic dermatitis. But we have to be careful. Again, you have to be careful not to confuse positive skin tests, positive blood tests with an actual food allergy. Okay, so example, in India, this is one center in Karnataka. So when they looked at just sensitization, both in children and adults, very high rate of adults and children were sensitized. But when you look at the history, did anything happen when the child or adult took the food? A very, very low percentage actually had a reaction. And in this case, and this is from Dr. P. Mahesh, he's in Mysore, one of the food experts, food allergy experts in India. So in his study, found that this sensitization was mostly for shrimp, eggplant, banana, rice, and chickpeas. So a little bit different from what we see in the West. But again, does this mean that does this translate in food allergy? No, it just means that these are common foods to which Indian population is sensitized to. And again, this is reflective of the diet. Again, the only way you can be sensitized to food is through exposure. Okay. Now, one thing about food allergies, which is kind of unique, is that a lot of the food allergens can actually be outgrown. And so if you look at the natural history of food allergies, most children, and we're not talking about sensitivity, we're not talking about pure sensitization, we're talking about actual clinical allergy. Most children eventually tolerate milk, egg, wheat, and soy. Okay, and so here are some examples. This is, patients with a true cow milk allergy, and as you can see, with age, eventually most children, once they become adults, their milk allergy is outgrown. Now, on the other hand, the higher the IgE level, the more likely that the allergy may persist. So those, for example, who had a very high IgE levels of cow's milk, well, a lot of those, even as an adult, their allergy still persisted. Okay, so we see this with cow milk, we see this with egg. The higher the IgE level, the more likely the allergy will persist. We see this with wheat, okay, and we see this with soy. So the higher the IgE level, the more likely that this may persist. We also know that in cases of milk allergy, in cases of egg allergy, generally speaking, most children can tolerate, the egg protein if the food is extensively heated, so baked egg, or if the milk is extensively heated as well, so heated milk. And so one of the reasons why this is important is because if you're able to tolerate excessively heated baked milk or egg, then that actually accelerates development tolerance. Okay, so for example, here, if you look at those who were able to, if you're able to tolerate these foods in baked forms, you're more likely to outgrow the food allergy itself. And this has clinical implications. It means that, especially, again, this is only for milk and egg. The implication is you may not want to completely have the child avoid milk or egg. If they're able to tolerate in baked forms, it's actually better for the child to do so because they may outgrow their allergy faster than strict avoidance. Again, this only occurs, we only have this data for milk and egg, not for other foods. What about peanut? What about tree nuts? Well, peanut, unfortunately, only 20% of peanut allergic kids outgrow peanut allergy with age. Again, the higher the baseline skin IgE level, and also the size of the wheal. So when you do a skin prick test, you also measure in size, in millimeters, the wheal size. The higher the level, the less likely you are to outgrow it. So here's an example of at age 1 and age 4. This is looking at the wheal size of the peanut. The higher the level, the less likely you are to outgrow it. Here you have peanut-specific IgE level. Again, the higher the level, the less likely that you will outgrow it. All right, so these over here, milk, egg, wheat, milk, egg, wheat, and soy, good chance of outgrowing naturally, whereas tree nuts, peanut, fish, shellfish, sesame tend to be more persistent, generally do not resolve. Especially tree nuts, only 10%, outgrow tree nut naturally, spontaneously. So these are sometimes lifelong issues. So that's something that you have to be aware of. All right, so okay, this is kind of a summary slide, and I'm going to pause right here just to see if there's any questions. Okay, so these are different foods. This is the spontaneous resolution rate, and also by what age. And these are some of the prognostic markers, which essentially means it's based on skin prick test size and IgE levels. Any questions so far before I go on? And again, I would encourage all of you to keep your cameras on so I can see you. Okay, crystal clear? All right, so let's now look at, some of the guidelines. So how do you make a diagnosis? And I'm going to base this heavily on this. These are, based on US guidelines. These kind of date a little bit. These were published in 2010, but I think a lot of the information here still holds true. And so this is kind of the clinical aspect. So I think the first thing is you need to take a good clinical history. That is critical, especially when you're dealing with food allergies. You have to take a good history. You have to know, okay, the parent will come to you, say, my child is allergic, or the adult will say, I'm allergic. What does that mean? What were the symptoms? Was this IG mediated? Was this non-IG mediated? First thing is, what is the time course? So if you say it's an IG mediated reaction, then the symptoms have to occur within 2 hours. It's not like you eat the food today and the next day you get hives. No, it has to be within 2 hours because these are immediate reactions. Okay, this is mast cell driven. Second, what are the symptoms? Were they localized? Were they generalized? All of you should know that, if it's IG mediated, it should itch because you have mast cell degranulation. So you should have a rash. Most patients will have a rash, hives. They may get swelling. They'll have shortness of breath, wheezing, chest tightness, vomiting, nausea, vomiting, diarrhea, abdominal pain. In severe cases, they may have, drop in blood pressure. So you need to know what the symptoms were, what treatment was given, how long the symptoms last, and and very important, for hives. So if the hive is truly from a food allergen, it's not going to recur. Okay, so the mast cells degranulate, but then eventually the hives go away. But hives that last, so with food allergy, the hives should only last a few hours and they won't recur. So patients who have recurrent hives, generally it has nothing to do with the food allergen. So that's very important not to confuse the issue. Again, if you were to do blood tests, if you were to do skin test, especially in the Indian population, up to a quarter of patients will be sensitized to foods. It doesn't mean they have food allergies. So be very careful and don't rely solely on blood tests or skin tests. You really have to first get a good clinical history. Okay. And the clinical history will then guide what tests you order. It shouldn't be backwards. And I think that's kind of the challenge. So this is very important. And this is not just for food allergy, but any IG-mediated reaction, whether it's to a drug, or it's insect bite, insect sting, you have to know what are the signs and symptoms of mast cell degranulation. So itching, hives, flushing, swelling, those are very common. So skin, dermal findings, itching of the mouth, swelling of the tongue, itchy throat, Very important to ask about, breathing. So, the larynx is a very narrow portion. It doesn't take much swelling, especially in a young child, to completely close up the throat. So it's important to ask about it. GI symptoms would be immediate vomiting, immediate diarrhea, immediate cramping. Lungs would be shortness of breath, coughing, wheezing, and then cardiovascular would be hypotension, tachycardia. So these are all signs of mast cell degranulation. All right. So then, also in the history is, it has to be reproducible. So let's say if you're allergic to peanut, well, many times the person has had repeated exposures. So you have to ask, okay, so you think you have peanut allergy, well, what has happened? Does it happen consistently? Also, there's a notion of threshold. What threshold? What quantity? Because, sometimes even in allergic patients, they can still get by with small quantities, nothing happens. But then if you take a larger quantity, it will cause mast cell degranulation. So quantity is important. What form? Was it baked? So was it extensively heated? Like, or was it uncooked? Okay, so that gives you a threshold, especially for egg and milk. And then you look for cofactors. So sometimes, and this is important with food allergies. So these are cofactors that actually can lower the threshold for mast cell degranulation. So, so you ingest the food, but on top of that, if you're sick, let's say with a viral infection, if you have uncontrolled asthma, if you have consumed alcohol or aspirin or NSAIDs, in addition to the food, or if you're under stress, or if you eat and exercise, these are all what we call cofactors that lower the threshold for mast cell degranulation. So you're more likely to have a reaction. Okay, so it's important to inquire about these. And you need to think about the differential. Okay, so anaphylaxis could be from many things. It may not be from the food, Was there a medication that the patient took? Was there an insect bite, insect sting? Sometimes it could be idiopathic, so you have to think beyond just food. Many times, because food allergies and eczema go hand in hand, oftentimes they'll blame the food for the eczema flare, but realize that in reality, eczema can be a lot of other things can flare up eczema, not just food. So irritants, changes in weather, humidity, infections, those are the common causes of eczema flare, not necessarily the food. GI symptoms, just because you have an upset stomach doesn't mean it's a food allergy. A lot of times you can have reflux, you can have a GI infection, it could be parasitic infection. Lactose intolerance is very common among Indians. So again, it could be a non-food allergy related problems. And then I would say in children, acute urticaria oftentimes are due to viral infections, okay, not food allergies. And chronic urticaria is never caused by a food allergen. So a person who has recurrent hives is not a food, okay? So it's very important to think about the differential diagnosis. Another aspect which many people confuse is, doctor, I'm allergic to the food. Well, things like spicy foods, hot foods still cause rhinitis. That's not a, that's a what we call gustatory rhinitis. It's not a food allergy again. That's just because when you eat spicy foods, when you eat hot foods, it induces a local cholinergic discharge, parasympathetic discharge, and so your nose can run. You can be sneezing, but that's not rhinitis very rarely is caused by food allergy. We mentioned this food poisoning, not uncommon, especially if, with uncooked meat, uncooked fish. You can have food poisoning. And then you have people who, especially people who have behavioral issues, psychiatric disorders, they may have, we see this list, an example would be anorexia. These patients have, often not well, they often restrict their food intake anyways, and they'll have severe food aversions, and sometimes so severe that even at the sight of the food, they'll get nauseous. So you have to look at do they have an underlying psychiatric disorder? Patients with neurodevelopmental disorders, oftentimes with texture, there are adverse to certain textures, like children with autism, and they're very picky about certain textures. And so these are other, reasons why they may not like certain foods. Okay, and then we talked about pharmacological effects. Caffeine is a good one. Also niacin. A lot of times patients, are on taking a lot of, multivitamins. And so niacin can cause flushing. And many foods also contain high levels of niacin. So these are things that you need to be aware of. It's also important to know that in general population, again, the word food allergy it's very confusing for the general public. And most, I would say 90% of the time, what the patient is talking about is not a food allergy. Okay, so most concerns about food allergy are misguided. And unfortunately, what happens is that patients come to you with lab results. They've had IG testing to multiple foods, and you look at the report and everything's positive, and now it's very hard to sort out what's real and what's not real. Okay, so again, just having IgE antibody in the absence of clinical symptoms doesn't mean anything. Just like in rheumatology, positive innate by itself doesn't mean anything. It doesn't mean you have underlying connective tissue disease. You need to sort out through history. Don't just look at lab reports. And unfortunately, unfortunately, this does happen. And oftentimes you'll see children very malnourished because now the parents falsely believe that their child has multiple food allergies, so they restrict their diet severely. And this can lead to unnecessary anxiety, can lead to malnutrition. And also in young children, when you avoid a food, you actually may increase the risk of an actual food allergy because you lose the tolerance. We see this many times, especially in young kids. Okay, so regular exposure to food actually helps you become tolerant. When you deliberately avoid a food for long periods of time in a child, you can actually develop a true food allergy. And one of your roles as an allergy specialist, and this is what we do, is to perform food challenges in the office to help delabel. All right, so what to do and what tests we use? Well, skin prick tests, help identify foods when you suspect an IgE-mediated food reaction, definitely you can do a skin prick test. Many times, I would just do a skin prick test with the actual food itself. There's no need to use commercial antigen, just have a patient bring the actual food, put the food on the skin, do a skin prick test. And what you want to see is there should be a wheal size greater than 3 millimeters, greater than the negative control. Okay, but again, the positive skin prick test alone is not diagnostic of a food allergy. I mentioned certain thresholds. So in the case of foods, the size of skin prick test, okay, the higher the level, the higher the size, the more likely that you will react to the food. But it doesn't tell you anything about the severity. So that's important not to, on a skin prick test, you can't say, oh, you're severely allergic to the food. What you can say is, okay, you are highly sensitized. Okay, but just because you are sensitized doesn't mean that the reaction will be more severe. So that's a very important concept. Okay, the higher the level doesn't mean necessarily you'll have a more severe reaction. It just means you are more likely to have a reaction. Okay. And by the way, this is my own skin test report. Okay, so this was just to give you an example. So I trained at Mayo Clinic, and this was me back in 2002. And again, I do have a lot of environment allergies, which you can see here. But what I want to point out is, this is an example of what not to do. So if you look at I do have a true food allergy to buckwheat, which is right here. So with buckwheat, I actually do get anaphylaxis. So this here, is a true positive. But if you look at my other skin tests, I tested positive milk, I tested positive oats, potato, rice, rye, beans, different beans, lima beans, almond, cashew, hazelnut, walnut. And I can assure all of you, I eat all of these foods and nothing happens, including, these big ones like almond. The size of the almond, 7 by 5 plus pseudopod. Just because my skin test to almond is positive doesn't mean anything. So the point here is don't blindly just get, all it means is as I'm sensitized. Yes, I have IgE antibodies to almond, but it doesn't mean I'm allergic to almond. Okay, so history is very important. And I would encourage, and unfortunately this happens all the time. Patients come with reports and now you're stuck with a report. But in the ideal world, in the ideal setting, first you do a history, then if you were to do skin testing or blood test, only do selective, very few. Don't get blind panels because that will confuse you. Okay. Now, what is the sensitivity? What is the false, the positive predictive value of skin test? What is the negative predictive value? Well, generally, it's pretty high in the sense that it will tell you, if your skin test is positive, it means yes, there's a good chance that you truly have IgE antibodies. Okay, so you're truly sensitized. That being said, occasionally you may get a negative skin test. Okay, so if you have a very convincing history of anaphylaxis to the food and the skin prick test is negative, then you want to be careful. You may want to repeat it, or you may want to just do a food challenge in the office. Don't just say, go home and eat the food, because occasionally, especially if you don't use the real food, if you use commercial extracts, the commercial extracts are not very good for fruits and vegetables, so you may get a false negative. In terms of in vitro blood tests, so the food-specific serum IgE, again, nothing wrong with the test. It will tell you, and one of the advantages, by the way, of getting serum IgE levels is that the patient doesn't have to stop the antihistamine. When you do a skin test, the patient has to get off of antihistamines for 5 days. So sometimes it's not practical, especially if they're coming from far away to see you. It's not practical to have them stop and come back a second time. So blood tests are good, and I use them, but just realize the caveats that it's not. It just tells you if you're sensitized to the food, doesn't tell you if you're allergic to the food. But same way, the higher the level of Ig, the more likelihood that you will react to the food, but it tells you nothing about the severity of the reaction. And similar to the skin test, occasionally, the Ig may be negative, so maybe a false negative. So if you have a good history, strong history, either repeat the IgE level or do a food challenge. Okay, no test is 100%, reliable. So you have to use clinical judgment. So ultimately, the diagnosis of food allergy relies on food challenges. Okay, so the gold standard is a double-blind, placebo-controlled challenge, which means that you as a clinician don't know if you're giving placebo or if you're giving actual food, and the patient doesn't know if they're receiving placebo or actual food. That's the ideal. And by the way, why do we use placebo? Because some patients have convinced themselves that they're allergic. And they're so convinced that when you give them food, they'll say, oh yeah, I'm itching. So there's a level of, so to truly sort out, is this real or not? Ideally, you should give a placebo. So obviously, if the child or if the adult says, "Oh yeah, I'm having reaction to placebo," then you know that this is, it's mostly anxiety related, and we see that we routinely. You'll be surprised how many times I give placebo, and patients complain. We see this in drug challenges too, because again, psychology is such that if the patient is so convinced that they're allergic to something, they'll have symptoms. And sometimes even the anxiety itself will cause them to have welts. So anyway, so now for practical reasons, though, it's almost impossible to do blinded double blind. So most of us, we do open food challenges, where, as a clinician, you know what you're getting and the patient knows what they're getting. And when do we do food challenges? Obviously, it's in this category where you have intermittent risk. Okay, so this is where, okay, yeah, the test is positive. Like, for example, here, yeah, a lot of these are positive. Okay, especially like almond, it was highly positive, but does this mean anything? If you look at the history, you ask the patient, did anything happen? They said, I don't know. No, I don't think so. Well, these are what we call intermediate risk. So the skin test is not negative, the blood test is not negative, but the history is kind of weak. So a lot of these times, you do challenges when you think it's probably nothing, and these are good rule outs. Because the last thing you want to do, just like with drugs, the last thing you want to do is have the patient think they're allergic to the food. So when the risk, when the risk is kind of intermediate, these are the ideal candidates where you just challenge them with the food. Okay. Now, on the other hand, if there's a high, like with buckwheat, I have a positive clinical history, I anaphylaxis to buckwheat. And so I'm telling you I'm allergic to buckwheat and my skin test is positive, well, then obviously there's no need to do a food challenge. Okay, because the patient is telling you I'm allergic to buckwheat, this is what happens, and you have a positive skin test. So again, high-risk patients, when it's obvious, you don't need to do a skin test, you don't need to do food challenge, but when it's not obvious, that's when you do food challenges. Okay. So how do you, and by the way, the other thing is you can do cutoffs. So sometimes based on the size of the wheal or based on the blood level, you can sort of tell the likelihood of reacting. Okay, and we do have established cutoff levels, and these are the cutoff levels for individual foods. Okay, so it also depends on the age of the child. It also depends, whether they're infants, whether they're older children. But what this means is for example, the cow's milk specific IG level is above 15, there's a 95% positive predictive value. Or if my skin prick test size, the wheal size is more than 8 millimeters, there's 95% positive predictive value. So there's no need to do a challenge. I know that the child will react. So having blood test results, having skin prick results, will help you guide also. Is there a need or not to do a challenge? Okay, so you look at the positive predictive value, you look at the negative predictive value, and then you decide, is it necessary or not? And again, these cutoffs are different for different foods. It's not the same cutoff. And again, this is the problem with in vitro blood tests. They don't tell you what the cutoff levels are. It'll just give you class 0, 1, 2, 3, 4. Right? So you have to look up these things to know what the values mean. So for example, with sesame, the level has to be very high before you say, okay, this is a true food allergy. This is a person who likely has a true food allergy to sesame. Okay, so the cutoff varies with the food. Now, another thing I want to address, because this has become very prevalent, what we call component resolved diagnostics. So this is, when we look at specific IgE, okay, that's one thing. You're looking at the IgE level to the entire allergen itself. So, what is component resolved diagnostics? So this is where, as I mentioned on the food allergen, there may be certain sites. Well, let me re-explain. So now you have recombinant proteins, okay, which you can test for, which allow for a better assessment of Ig binding to individual proteins within the allergenic group. Okay, and I'll explain what this means. And the reason why we do this is because it allows us a better diagnostic accuracy for predicting clinical reactivity. Okay, so it's a second level. So this here is kind of the first level. Okay, yes, it's positive. But now my question is, okay, well, okay, I understand it's positive. For example, okay, let's say milk is positive, but how will this tell me if the child can tolerate egg and baked goods? Or will this tell me, what I want to know is, okay, yes, it's positive, but can I do a challenge to heated milk? Okay, this is where component testing can play a role. This is like a second level. okay, so let me explain, or I'll try to explain one by one. So when you look at component resolved diagnostics, okay, so there are different, you can get IgE antibodies to different components of the allergenic protein. So you may have IgE antibodies against what we call CC determinants. CC determinants are what we call cross-reactive carbohydrate determinants. So on plants, on insects, so on plant food bases, on insect, you have these carbohydrates, okay? And in certain individuals, you can develop IgE antibodies against these carbohydrates. Okay, but this is of no clinical relevance. Okay, as you can see, about 25% of the population will have IgE antibodies. So if you were just to do, an in vitro blood test looking at the whole antigen, you may have mild sensitization to those antigens. But if the IgE is directed against the carbohydrate portion, then that is of no clinical relevance. Okay, so you can ignore that. This will not cause clinical reactions at all. Okay, with the exception of one. The exception is called alpha gal, which is a different story. But generally, IgE against CCD will not cause any issues, so you can ignore it. Then you have what we call profilins and PR10. Okay, so in the absence, okay, what does this mean? So you can become, hold on. Okay, I think I missed one. Okay, here we go. Okay, so you can, and here's an example of people with oral allergy syndrome. So you can be highly sensitized to a homologue of the birch pollen, or the grass pollen, or the ragweed pollen, or the mugwort pollen. And because of the homology in certain, fruits and vegetables, if you were to do a skin test to that fruit or vegetable, or to that nut, or if you were to do the blood test, the blood test will become positive. But if you do a component resolved diagnostic and you see that, okay, you are actually reacting to the birch pollen homologue, which is PR10, then you know that, okay, you probably can still tolerate the food. The reaction will be mainly local reaction, consisting of oral allergy syndrome, localized itching, localized swelling. It generally will not cause anaphylaxis. Also, these are heat labile. So when you heat up the food, generally that goes away. Okay, so this helps you, in assess, okay, well, yes, the blood test is positive, but if it's mainly due to PR10 IgE antibodies, then it doesn't necessarily mean you have to avoid the food. Okay, so this is what we call, and by the way, profilin is also very prevalent. So profilins actually are most of the time are completely asymptomatic, and so you don't have to worry about that. Okay, so no need to avoid the food because low risk of anaphylaxis. And by the way, again, going back to my story here, if you look at my skin test, if you look at my birch, I'm highly allergic to birch. And some of those foods here that are positive, yes, I do get a little itching of the mouth, but that is due to food pollen syndrome. It's not this will not cause anaphylaxis. So it's important, again, to take a good history and also to understand that sometimes foods cross-react with pollens. On the other hand, you have what are called lipid transfer proteins and storage proteins. These proteins are highly allergenic and actually can cause systemic reactions, and they're also heat resistant. So just heating of the food will not destroy lipid transfer proteins or storage proteins. So if on your component resolved diagnostic test, if this becomes positive, then you truly have to, the patient is more likely to have a systemic reaction. Okay, so what does that mean? Let me give you an example here. Okay, so here's an example of component resolved diagnostics. So what you will get is when you do these tests, you'll get a report. Okay, yes, peanut is positive, and generally what they do is these are called reflex tests. So they will only run a report if the IG against peanut is positive. If the IG against whole peanut is negative, you're not going to get this report. But if it's positive, then it will do component resolved diagnostic on the peanut itself. Okay, which component is positive? Okay, and so if it's just error H8, well, we know that's from, that's a homolog of birch pollen. So it means the person probably is allergic to birch pollen. This will probably result in oral allergy syndrome, but will not result in anaphylaxis. Whereas if these are positive, especially error H2, then this is storage protein. So there's a great chance, more significant chance of reacting. Okay, so again, this is mainly it's a second level test that gives you more accuracy and will also help you determine whether you should challenge or not the patient to food. Okay, so here's some other examples. So you have peanut here, you have hazelnut, walnut, Brazil nut, cashew nut. And again, what you're looking for is, am I sensitized to a lipid transfer protein? Am I sensitized to a storage protein? If yes, you have to be careful. And this also extends to other foods, egg, milk, where you have a heat-resistant protein. Okay, like with egg, if the GALD1, which is ovomucoid, which is highly resistant to heat, well, if you're highly sensitized to this protein, you probably cannot even tolerate baked egg. Okay, whereas if most of your IG is against ovalbumin, albumin, as you can see, is heat labile, then you can probably tell the child, okay, you can go ahead and eat egg and baked goods. Okay, so this gives you an idea of how to, it's kind of a second level tool. Okay, but history is always important, more so than tests, rely on clinical history. So here's the same table with different cutoff levels. This here incorporates component resolved diagnostics. So this is kind of the same table as here. Here you just have the IgE levels against the whole antigen, and here more specifically, you can, based on the component result test, you can determine, is it safe or not to do a food challenge. Okay, and again, these are things that you have to, these are tables, there are different cutoffs for different foods, for different components. These are things you just have to know. Okay, if that makes sense. So again, what is the advantage of component resolved diagnostics? It helps distinguish between true allergens from cross-reactive allergens. In food allergy, it helps better predict the risk of, what kind of reaction are you most likely to get? Are you most likely to just get no reaction or localized reaction versus, anaphylaxis? So it's a tool that guides you, but ultimately history is the most important thing. And you really have to, again, history, and the ultimate test is the food challenge. Okay, so okay, but before we do that, let me see if there's any questions. Any questions before I go on?
So there are quite a few questions, but I think we are already at the 1 hour bracket. So if we can
Okay.
take the questions at the end, if that's possible.
Okay. All right. So here's, let's talk about food challenges. So how do you conduct them? Again, this is not for everyone. So if you have an intermediate history, so you have a weak history, but the test and assuming that the skin prick test and size, and assuming that if you do get a blood test, if it falls, if the levels falls, below the threshold, then go ahead and do the food challenge. If, on the other hand, the history is very strong, very convincing, if the tests are positive, especially if the tests are beyond, what we call the cutoffs, then there's no need to do a food challenge. Okay. So how do you do this? Well, it's done in a clinical setting, usually done in the office. You don't necessarily need to do this in the ICU setting. But there are certain things you need to do. You need to be able to treat anaphylaxis should anaphylaxis occur. So you should have epinephrine on hand. You should have oxygen on hand, albuterol, nebulized albuterol. You should have antihistamines. And by the way, we have patients discontinue antihistamines because antihistamines can mask mast cell degranulation, right? It'll mask the hive. So you stop the antihistamines a few days before. You make sure the patient's not ill. If they have fully controlled asthma, you need to control their asthma before proceeding with the food challenge. Make sure their skin is not too much covered in eczema so you can actually appreciate hives. And you basically give them the food, okay, the actual food to which they think they're allergic to. Now, the amount of food, it depends on it's basically a serving size. Okay, so you give the normal serving size, so that will depend, of course, on the age of the child. Small child will require less food, adult will require more food. And what you do is you divide up serving size into different portions, and you start with low dose, and you generally double the dose until you hit, the serving size. And this is given every 15 minutes. And you monitor, for signs of symptoms of anaphylaxis. There are various protocols. You can do it in 4-dose step, 6-dose step, 8 steps. It depends on how you want to do it. And again, you start with a low dose, and then you increase. And the final dose, if they're not having, the final dose is usually the bigger portion. And depending on the age of the child or the adult, these are some standard portion sizes. Okay, so you just buy the real food, and you follow these, and so you would divide up. This would be this would be the serving size. So you take the serving size, and if you're doing 8 doses, you would divide it by 8. If you're doing, in a 4 doses, you divide by 4. So this is how you would do it. And again, you start low dose, and every 15 minutes, you just give the food, make sure and monitor, make sure they don't have any side effects. Okay, so what do you mean by side effects? Well, there's subjective and there's objective. So sometimes you may not see anything, but if the patient really says, no, something's happening, I'm itching, okay, then, use your clinical judgment. Then you may need to stop. Again, this can be a challenge because a lot of these patients, they're so afraid that they may tell you, and so a lot of it could be stress. So you have to use your clinical judgment. Sometimes what we do is we say, okay, we'll just pause here. Let's have them drink some orange juice, see if the symptoms resolve. Many times, if it's psychological, the symptoms will resolve on their own, and you can continue the challenge. On the other hand, if you do see objective signs like this, if truly you see new hives, new swelling, new rashes, or if you hear wheezing, shortness of breath, or if they vomit, or if their blood pressure drops, obviously then these are objective. So then you need to stop. Okay, so you need to stop the challenge and treat them appropriately, whether it's with epinephrine or antihistamines or bronchodilator treatment. You need to stop. So this is, again, you have to use clinical judgment. In general, food challenges are very safe. Do we get reactions? Yes, sometimes we do get reactions, but as long as you know how to treat anaphylaxis, it's generally can be safely done in the office setting. Okay, but you need to have staff, so you can't just have a child eat the food and then go away. Someone has to be checking on them every 15 minutes. All right. Now, if the test is positive, okay, so let's say yes, you truly have a food allergy. How do you manage? Well, for the most part, you need to avoid the food. Okay, there's some exceptions, like if it's egg, okay, and you can tolerate egg and baked goods, and that's fine. Or if it's milk and you can tolerate milk and bake in extensively heated milk, that's fine. But for the most part, we say, strict avoidance, especially, when you go to a restaurant, at school, at work. If in doubt, just avoid the food. If you have multiple food allergies, we generally, have them see a nutritionist, just make sure that they're getting adequate nutrition. You want to write down a written emergency action plan, which basically means epinephrine. Okay, so in India, unfortunately, auto injectors are not available. So what we would do is we drop epinephrine in a syringe. The dose is 0.15 milligrams, roughly, in children less than 12, and 0.3 milligrams in children greater than 12. So you drop those syringes in a pre-filled syringe. We give them two, put them in a spectral case, which basically protects it from sunlight. And you need to tell them if you're having anaphylaxis, you need to give epinephrine. It's given IM, okay, IM in a thigh. Okay, and many times also we recommend, having a little bracelet just to identify that, yes, I'm allergic to this food, this food, this food. This is an example of a written action plan. It tells you, IM, okay, how much to give, what dose to give of epinephrine, and then if you want to give antihistamines, if you want to give steroids, that's also fine. But the most important thing is you need to write down, okay, what are symptoms of anaphylaxis, and the drug of choice is epinephrine, okay? Not steroids, not antihistamines. You want to give immediately. Okay. So here are the doses given the lateral thigh IM. The reason for lateral thigh is because that's the epinephrine gets absorbed more quickly when you give it in the lateral thigh IM. It gets absorbed within 8 minutes versus giving sub-Q and giving it in other places. The reason for two doses is that sometimes, not always, but in 20% of the time, patient may need a second dose. So ideally, two doses. And then, we tell them, okay, see someone, either call or go to emergency room. And that's when you do the secondary things, steroids and that sort of things. But the main thing is epinephrine. That is life-saving. And who are the risk, who are the people who actually die from anaphylaxis? Well, it's the youngsters, the adolescents. These are, teenagers who ignore their symptoms. They're more risky. They're more risk takers. They say, oh, no, I'll just take antihistamines. These are the people who will, potentially can die. Also, those who have poorly controlled asthma, those who have, obviously not taking epinephrine is a risk factor. Other risk factors, if they have the cofactors, exercise, alcohol, NSAIDs. If you're on a beta blocker, as you know, it blunts the effect of epinephrine. And so those are also patients who likely, are more at risk for dying. Also, ACE inhibitor use is another risk factor. So bottom line, avoid the food, that's the general recommendation. The exception would be if it's just limited to the localized symptoms or allergy syndrome. Those generally don't cause anaphylaxis. And as I mentioned, egg or milk, most of the time you can tolerate in baked goods. It's important also to, read labels. Unfortunately, the labeling laws vary from country to country. So when in doubt, just avoid. And most accidental reactions occur outside the home where you have no control. You ask the vendor, is there a peanut in there? They say no, but how reliable is that vendor, right? So it's really important. Just use your judgment. If you're not sure, just don't eat the food. That's my recommendation. I'm going to skip this. This is cow's milk allergy. Um, the bottom line was here. Let me just one word for cow's milk allergy. So most of the time, it's not a true IgE-mediated reaction. It's basically intolerance of the milk protein. So if you have that, then you want to avoid full milk. You want to also avoid soy, because a large percent of these patients also have soy protein intolerance. You want to give an extensively hydrolyzed formula. And most children with calcium milk protein intolerance, as they grow older, it resolves by itself. But this is not a true, most of the time, it's not a true IgE-mediated reaction. It's just intolerance to the calcium milk protein. All right. And the last thing, very quickly, I just want to give a word on anti-IgE therapy. As you may know, omalizumab is approved for food allergies, at least in the United States, in children with food allergies down age 1. Idea here, what is omalizumab? Omalizumab it blocks IgE. So the rationale is, if you give omalizumab, you are binding serum IgE. Therefore, you're downregulating the IgE-specific mast cell receptors sitting on mast cells and basophils. And so this was based on the Outmatch trial, where they took children, 177 children and adolescents who had both peanut and other food allergies. So you had to have at least peanut and 2 other food allergies. It could be milk, egg, wheat, cashew, walnut, or hazelnut. And these children were randomized to either omalizumab or placebo. And at 16 weeks, okay, they actually challenged them not only to peanut, but they also challenged them to their other 2 foods to which they were allergic to. This is how they were challenged. And this was the primary endpoint. So at 16 weeks, you had patients, who previously reacted to less than 100 milligrams of peanut protein, and now they were able to they didn't react at all to 600 milligrams of protein. And the way the challenge was done, you start at 1 milligram, 3 milligram, 10 milligram, 30, 100, and 300. So the cumulative dose was over 1 gram of peanut protein. So 2/3 of children, who previously were not even able to tolerate 100 milligrams of protein, essentially tolerate a cumulative dose of 1 gram protein without any adverse reactions, versus only 7% who were on placebo. And then these were the results of other food challenges to their other foods, where the threshold was at least 1,000 milligrams of the food, which means a cumulative dose of over 2 grams. And you can see a large percentage of them not only tolerate peanut, but they tolerate, cashew, egg, milk, walnut, hazelnut, wheat. Here's these are the Kaplan-Meier curves. And you can see, so in addition to tolerating, peanut, a large percentage of them could tolerate 2 food, even 3 foods. And so this may be an option in the future for children with severe food allergies, especially multi-food allergies, where it's hard to avoid. Caveat in this study is that, so the IgE, the dose of omalizumab is based on the total IgE level. And so the higher the baseline IgE level, the more omalizumab you have to give. So there's a practical limitation. So those patients in the study, their IgE cutoff was 1850. So if their IgE level was over 1850, they didn't qualify. Also, their asthma in this trial, if they had asthma, their asthma was controlled. They didn't allow fully controlled asthmatics. Okay, so anyways, in the future, this may become a viable option. So take-home message: prevalence of food allergies is increasing. It can result in anaphylaxis. Fortunately, in India, the actual prevalence of food allergies is quite low. On the other hand, the sensitization rate is quite high, so it's really important to sort out, what's true food allergy, what's not food allergy. The goal of the allergist oftentimes is to rule out. That's why we do a lot of education. We do food challenges to reassure parents that no, your child actually is not allergic to the food. The tools we use, skin test, food-specific IgE, those are important tools. Again, remember that, remember limitation. They only tell you if you're sensitized. It doesn't tell you anything about, what will actually happen. So clinical history is important. It's important to know how to do food challenge and which patient to do food challenge and what patient you don't do food challenge. And then management thus far is mainly avoiding food carrying epinephrine, but in future, if it's affordable, then omalizumab may be an option in some cases, especially when avoiding the food can be challenging. So I'm going to stop there. Be happy to answer any questions if there's time.
Yeah, I think we've kept people waiting for answering the questions even in the last talk. So if it's okay, we'll take 15 minutes for Q&A.
Yeah, go ahead.
Okay.
You want to just tell me the question so I can.
Yeah, yeah. So the first question is from Reena ma'am. And can you explain a bit more about the cofactors of allergy and how poor sleep and exercise precipitate food allergy?
Yes. So that's a good question. So exercise, well, first of all, it may have, and this is just speculation, but you tend to the gut has a lot of histamine, and the gut actually has mast cells as well, and so when you exercise, um, again, these are speculative theories, but you tend to absorb more of the food. When you exercise, you increase there's certain, when you exercise, you're also, um, there's in general, you are more prone to vasodilatation when you exercise, because your body needs more blood flow. So that is, potentially one reason. And by the way, that's also the reason when we do OIT, which I didn't talk about here, but when you do oral immunotherapy, you tell the patient do not exercise, no vigorous exercise for 2 hours afterwards. So um, beyond that, I'm not sure we fully understand why exercise is a cofactor. There is one particular food, which is wheat, it's a rare entity, but it's called wheat-dependent exercise-induced anaphylaxis. This is when you have antibodies against omega-5 gliadin, where eating wheat itself doesn't do anything, but if you eat the wheat and you exercise immediately after, you can get anaphylaxis. And again, there are many theories about how this works. I'm not sure anyone truly knows, but it is a cofactor. And so um, it's something that you want to ask about. And it's more important, like when you do OIT, oral immunotherapy, you have patients who tell them not to exercise for 2 hours after they dose. The
Yeah.
other cofactor that's more easy, to understand, alcohol, is a mast cell destabilizer, and alcohol also induces, it's a vasodilator. And then NSAIDs, and we know this, in patients with chronic urticaria. If you have a patient with chronic urticaria, you give them NSAID, 25% of the time their hives get worse. And this is because you're inhibiting COX-1, so you're upregulating lipoxygenase pathways, so you're producing more leukotrienes. That would explain NSAIDs. Again, these are just theories. I don't think anyone knows truly.
Yeah, thank you so much, sir. Just because you've touched upon the oral immunotherapy, could you just explain to the audience what is oral immunotherapy and what's the current evidence base regarding it?
Sorry, your computer froze. Can you repeat the question?
Yeah, uh, since you've just touched upon or spoken about oral immunotherapy, I was just
Yeah.
asking if you can just tell the audience what's the current available evidence base regarding oral immunotherapy in patients with food allergy.
Well, it's what's the current evidence? Well, it does work. So first of all, none of these therapies are curative, okay? Nor omalizumab nor OIT is curative, in the sense that unlike allergy immunotherapy, where you give treatment for 3 to 5 years and you stop, there is no such thing as, or there is very little unsustained, you know, sorry, sustained unresponsiveness. Means that when you stop the drug, or when in this case, when you stop the food, generally you lose your protection. Okay, so the concept in a nutshell, the concept of oral immunotherapy is you have patients who, in spite of good efforts of avoiding the food, they find it difficult, and they've had multiple accidental ingestions. They've had, resulting anaphylaxis. So this will, as you can imagine, it will cause a lot of anxiety for the child, for the parent. And so the idea here is by giving on a sustained basis the same food to what you're allergic to, you raise the threshold. So the idea here is, and by the way, oral immunotherapy works best in young children. It doesn't work as good in adults. Okay, young means the earliest you start, the better. And so by giving the food every day, it induces, it upregulates regulatory T cells, which kind of put a pause, which kind of shift the immune response from Th2 to Th1. But it's a temporary effect. And what it does is when you start, reducing your IgE level and you're increasing your IgG4 level, is at least temporarily, you are less likely to have mast cell degranulation. You're less likely to have anaphylaxis. So it gives you a safety threshold. Okay, so let's say if you consume 1 gram of peanut protein every day, well, and you're doing this on a daily basis. Okay, so then that means at least you're safe at 1 gram. So it's very unlikely that you'll have that much accidental exposure. So it protects the child. Does it cause permanent immunological changes? Does it help you outgrow the food allergy? That's the controversy. Yes, it can. In certain cases, you can actually outgrow the food, but we don't have long-term data, and we know that it only works in some certain subset of patients, and these are patients in which you do oral immunotherapy very early, okay, at a very early age. The confounding factor is that we know that certain individuals and certain foods naturally you outgrow anyways, like milk, egg, wheat, you know. So was it the oral immunotherapy, or is it just the natural remission? That's the controversy. And we don't have good biomarkers right now. And I would say, this is something that those who do oral immunotherapy, you have to very carefully select your patients. You have to have patients who are highly committed, highly adherent, because this is not something you can just willy-nilly take. When you give oral immunotherapy, patients have to be compliant. The child has to consume the food every day. If not, if they stop the food, many times within a few weeks, you lose the tolerance. So difficult question to ask. I think we need to have long-term studies.
Oh,
Right now, there's only one FDA-approved product, and that's called Palforzia, and that's for peanut allergy. That the peanut is in a capsule form, and we use that in children. But this is not something I would recommend, um, outside of people who are experienced in this field.
yeah. So you have to be a good food allergist before you start practicing oral food therapies. Yeah. So
Yes.
this question on, is there a percentage of false negative SPT despite positive clinical history? And a corollary, that is oral challenge dangerous in such a scenario?
Yeah. So so if you have a very strong history, and if the skin test is negative, first question is, okay, well, do I have good quality antigens? And sometimes certain foods, the commercial extracts are not good. So I would actually repeat the skin prick test using the real food. Okay, put the real food on the skin, do a skin prick test, and see if it reacts. If it doesn't react, and so there's several explanations. One is if you have a person who recently had anaphylaxis, you'll have mast cell depletion. This occurs, it takes 4 weeks for the mast cells to replete themselves. And so the first question is, okay, is this, so generally we don't do a skin prick test very close to an episode of anaphylaxis because you may have depleted your mast cells. And that's why they don't respond. So you generally wait 4 weeks and then you do it. Alternatively, you can get in vitro blood tests. So in vitro blood tests, that you can get anytime. It's not dependent on your mast cells. It just because all it's detecting is presence IgE or not in the serum. Now, assuming that it's still negative, but if you have a strong clinical history, okay, well, then yes, then you do a food challenge. But obviously, you have to do it carefully. You have to do it carefully. But it's one of these things that if it's a food that is common, that if it's a rare food, then you say, okay, don't worry about it. But if it's something that's common, and then yes, you know, you know, and again, when you do food challenges, remember that we're doing it in a monitor setting. You're doing a very small dose and you're observing for anaphylaxis. We're not telling these people do food challenges at home. This is done in a monitor setting. So if you do have a reaction, you can treat. So in that sense, yes, it is safe.
Yeah.
The other question, I guess, is FPIES, right? Is that you want me to address that? So FPIES is a totally different entity. It has nothing to do with IG. That's an entity where you get delayed reaction. Usually 6 hours later, you get profuse vomiting to the point of dehydration, diarrhea. This is very challenging because there's no markers. The skin test, the blood test will be negative. So, and the reaction is delayed. So, do we do a food challenge to confirm it? Ideally, yes, but here you're going to have this is going to be very challenging because you give the food and you have to monitor them for a long, long time because the reaction won't take place until 6 hours later. Um, and potentially, it'll cause profuse vomiting as you get to the point of dehydration. So yes, you can do it, but in this case, it's much more challenging for the average practitioner, who doesn't have time to monitor these patients for such a long period of time.
Yeah, you actually need them to be admitted, and sometimes the features could be quite severe. So the patient should be taken well in confidence that the reactions might be actually very severe when they present. And I think we're almost finishing. And are there any other questions that I can ask? There's this question on which placebo do you use in a double-blind placebo-controlled food challenge test?
Yeah, um, good question. Whatever you have. So if you're using caps, so again, this is more in the research setting, to be honest, but it's so in research setting, generally you put in a capsule. It's just a filler, you know. Uh, but you can do it, however you want. You can just give. In fact, what we do for food challenges, many times, we just give. Uh, you can. You can mix it with something because a lot of times people don't want to take the food, certain food they don't want to just take it, they want it mixed in either pudding or something. So you can say, okay, yeah, I mixed it. You just don't tell them. Just say, yeah, I mixed it in pudding or I mixed it in applesauce or, you just tell them, you just make up something. Say, I mixed it, but yet you didn't, and just give it. The point is, if the patient thinks that they're giving, and you don't, of course, you don't tell the patient they're getting placebo. Okay, that's but if the patient thinks so, and I will do this when I sense there's a lot of anxiety, I will give, I will just give them the pudding or the applesauce, and I'll say, yeah, I mixed it inside. So the child or will say, oh, they'll think that they're getting it. Um, so that's how you would do it. So it depends on the clinical context. But
Mm.
I think it is important to do because, and all of you, you can sense that there are certain people who are very, very anxious. And so you don't want to, just to make sure that it's not their anxiety, it's better to use the placebo.
Yeah. Thank you so much, sir. And I think we're already almost in the last minute. So I can frankly thank you enough. Can't thank you enough for the talk. This was a very comprehensive talk, and I don't think anyone could have done a better job covering everything that is important in food allergy in the time that was given to you. This it is a very large topic, even the IG mediated food allergies, and you gave them a very important gist and all of those tables regarding how much of a food challenge to do or what are the cutoffs for IG and CRD levels, even the brief introduction of component resolved diagnostics, all of that covers mostly what food allergies convey comprehensively. And we can't thank you enough. Thank you so much, sir, for the talk.
Yeah, thank you. And I would encourage you to read did you distribute the articles I
Yeah,
gave?
yeah. The guideline.
Okay. Yeah, that'll give you more, they'll do more justice. Again, it's hard in such a short time to cover and also to know what level, so, but anyway, I think, yeah, I think it's important. Bottom line is I think it's important, as rheumatologists to understand these things and to really get a sense of, appreciate, because you'll see this, every specialty sees these patients. It doesn't matter if you're an allergist or not, you'll see it in your practice.
Yeah,
Am
true.
I correct?
Yes, yes. We see it a lot, and there are a lot of misconceptions. Every patient thinks that they are allergic to something, and I recently had a patient who thinks that she's allergic to sugars, but then there are no. So whenever she eats something sugary, she has a reaction.
Mm.
What's the actual truth to it? You identify based on a strong history, but then there are
Yeah,
all these misconceptions, and the often the problem is that a clinician sees that test of an IG antibody that is positive across multiple food items, and we ensure that
mm,
the patient has a tough time finding food that does not have any of those things when they eat.
yeah,
So
yeah,
all of those
yeah.
things. So
Okay. All right. Thank you so much.
thank you so much, sir. Thank you so much for the talk. It was a wonderful talk. Wonderful talk.
Okay. Thank you.